On the provider side, so a patient is the lifestyle and their belief that this is going to be good. On the provider side, it's very important to fit into their workflow because provider, I'm lumping here any healthcare provider as well as outpatient clinic and others, and they have so much going on already. And if you want to use different technology, it has to fit in. And as Andrew showed here, example, it's already fitting in. That's the scale, and that's how seamlessly it has to fit in. And then the payer, of course, they are looking for is overall healthcare cost containment, but tied with the metrics of quality of the healthcare we're delivering. So I think one has to look at the completely all three constituents to be able to scale and be able to sustain. So I just want to now give you a couple examples that large scale. One is the diabetes area. Earlier this year, we launched a program called Diabetes Prevention and Control. So we have taken the two aspects. One is on the prevention side. We have partnered with YMCA, and there we are focusing on obesity and inactivity and behavior change. I'll show you in the next slide in a second. The numbers are huge. On the other side, those who have diabetes, we have partnered with Walgreens, and we are doing a quarterly review of their maintaining their compliance and performance. This is a solution that is fully covered, so those who opt in, participate, it's no cost to them. And our partners, YMCA and Walgreens, their reimbursement is tied to performance. So for example, YMCA program is 16 weeks. If the member does not go 4 consecutive weeks, they don't get paid at all. And so there's a pay for performance, if you will, is tied to it. So very quickly, why diabetes? As you know, there are nearly 1 in 4 American adults age over 20 is pre-diabetic. And so huge number. 57 million people are expected to, are projected to be pre-diabetic. And what's interesting, there's some data now that's showing something like a 5% reduction of body weight prevents over 50% reduction of their conversion from pre-diabetic to diabetic. This is some of the protocols we are working with CDC as far as what is done. So very remarkable if we can get people engaged. On the diabetes side, you've got 18 million people who have, majority of them type 2 diabetes. And again, there's what we are focusing there is lack of control of their blood pressure or cholesterol or activities. So those are the two groups that we are working on. Very briefly, what has happened, as I shared with you, some of the analytic and analysis information we have, we can get with over 75% accuracy prediction who could be the target of a pre-diabetic. That members, if they opt in, member services allows them, if they are in the bottom, the weight loss, then they are falling through the YMCA program. If they have diabetes, they're monitoring it. And on the right side, you have the member themselves through their website, they're able to see it. So that was the one program. Is more on the wellness and early chronic disease side. And then last couple slides, I just want to share the other program is there's a lot of attention these days is hospital readmission. There's this is the study from New England Journal of Medicine published article, and it's showing nearly 1 in 5 hospital discharge get readmitted in the hospital, so 18–19%, and this is showing you by state what percent is. What's interesting, as they analyze this data further, I know you can't see it, but that reference is here, but what this says that 76% of these readmission, they classify them as a preventable. If you get engaged with that patient, then you can prevent it. So this alone has, the projection is $17 billion healthcare costs annually just for hospital readmission within the 30 days. And Medicare and also Medicaid, many states have already implemented, and by 2 more years, they will not be reimbursing for the patient coming back to the same DRG. So the hospitals have a lot of interest in this aspect. So
you don't bring any Prozac samples when you present this, do you? Try to pass it out.
So 2 more slides, and then I'm finished. So this, one of the things was, you know, when the patient is discharged, they're asked to see their primary care physician. And this showing you in the bottom days after discharge versus the seeing the physician, if within the 10 days, if they haven't seen a physician, over 50% of them eventually come up in readmission. So that shows its importance of the follow-up the patient after the discharge. Another study, this is done by analyzing our own data, so it's not part of the New England Journal article, but again, looking at transitional care management system. And what it is looking at is the readmission days after discharge, if they are engaged with transitional care management versus not engaged, and you see statistically very, very strong differences, those who are engaged in especially in the first 30 to 60 days. After that, it starts to get a little less after 60 days. So the point here is that this all leads to that one has to really look at the continuum of care, not just episodic. And so my last slide is the key stakeholders for this is the patient we talked about earlier. They have to believe they'll improve outcome. And we oftentimes forget the caregivers. That's also very, very important. Those who are caring for, or I should say, non-paid caregivers, not the professional. These are the family members and the spouses and moms. And then on the right side, you've got already the providers and payer. And you have to look at the member or patient could be at any stage of time. So one of the things we are looking at is to wrap around all different stages, being all these stakeholders, and we are calling it telehealth as a service. It's for the continuum of care, not only just siloed or episodic. I thank you for your time.
You are seeing in payers and basically reaching around now doctors and hospitals coming right at the patients directly. Very interesting. This is going to be a new world order for us because you're going to get the doctors and the nurses out of the loop, which is not necessarily a bad thing. And I also think that the focus of what telemedicine, the ROI, is transitional care. The payers know right off the bat, with a high degree of certainty, who's most likely to be readmitted. And they know up front. So it's interesting how transitional care will be a very important part of telemedicine.